Hello and welcome to Community Connection, your window to the world around you. I have with me today a dear friend who is a pediatrician, Dr. Loubna Fakih, who is also the former chief of pediatrics at Oakwood Hospital in Dearborn. Dr. Fakih, welcome to Community Connection.
Thank you for
being here.
Thank you so much.
I've known you for a long time. And I've also known you to take such good care of every single child that comes into your office.
Thank you.
You're loving, you're caring, and you're knowledgeable. Those three things are invaluable in a pediatrician. Tell us what the most important thing is that you look for when a child walks into your clinic for the very first time.
You know, whether it be a newborn visit or a first-time new patient visit to my office, the first thing I want to do is connect with the parents and connect with that child if they're older. Obviously, if they're newborn, you're going to connect with the parents before you connect with that child.
Sure.
But if building a trusting, open relationship is the key to the parents being comfortable with you and being open and honest, and you being open and honest with them.
Absolutely.
To be honest. Yeah.
Absolutely. School is upon us, and I know you probably been very, very, very busy with physicals and all different kinds of health issues. Talk to us about what the protocol is at this time for youngsters going back to school, and you know what they need to do, what parents need to look for, you know, vaccines, physicals.
Absolutely. You know, physicals are, I believe, the utmost important, whether you're going back to school or, you know, for routine visits. But I really want to preach that kids should get annual physicals as they're older, but actually should come for normal routine physicals. As an infant, they start off young and they come in routinely, and we give them a schedule. But once they get to the age of 4 or 5, sometimes they kind of slip. But preschools get their entry physicals. We do at every physical, we assess their height, their weight, their vision, and the big thing is development, and making sure that the child is developing appropriately at every milestone, and catching anything early, because early assessment, you can catch things and try to rectify things a lot easier. Vaccines are important, and vaccines start obviously in the newborn stage.
Before we go to that, I wanted to ask you, in terms of growth, physical height growth, what is it that you look for, and what is it that tells you we have a problem?
Well, we actually assess their growth, and it's good as if they're routine patients of ours and they come regularly, we can assess their growth from period to period. So I can say, oh, from last year you grew 3 inches, which is an adequate growth for a child. And there's a difference between male and female. So we actually have them on a growth chart, and we plot them at every routine visit. And if there's times where they may be coming for something other than a well visit, I will see something, I'll assess that at that time as well. So there's always sometimes little red flags, and I'll say, oh, wait a second, you lost 2 pounds, or lost 3 pounds, or your height hasn't done as well as this. So it's always important to be routine, because the earlier we catch something, the better it is to treat and resolve, to try to find the issue or the problem.
So what would be one example of an issue with
an
growth?
issue with growth is, say the child has been at the 25th percentile. So we always rank these kids based on percentile. So 5, 10, 25th, 50th, 75th, 90th, 95th. And so if the child has been growing at the 25th percentile and all of a sudden stopped and from one year to the next dropped to the 5th, that's a red flag to me, saying, okay, what halted this growth? What else is going on? Did the weight also coincide and go down? If the weight didn't, the height did, something tells me I need to assess this at this time. So it's always important to have them come in annually. We can assess weight issues. If there's a height growth and growing normally, but the weight came down, what's causing the weight to come down? So we have a growth scale that we also go, but we also do BMIs, body mass index, basing the weight on height. For age, and that's an indicator for we keep that eye on health, and we're catching obesity with that. So again, routine visits are of utmost importance. Height, weight, check vision. There's a lot of times we check these kids, they don't say anything, but when we do a vision screen, we catch them and they say, oh, you know, something's wrong with that vision. Blood pressure. We've got a lot of kids that come in and we'll catch something, and we catch it early enough if we get them on there routinely and get them. Is their blood pressure up because of weight? Or is their blood pressure up something else going on? Is it a kidney issue? Is it a heart issue? You know?
Absolutely.
I'm not saying it's something wrong every time, but again,
there's a correlation.
There's a correlation. And then we bring them back just to make sure, is that blood pressure up because they're afraid? Is it fear? Or is it truly something going on?
Vaccines, you started to touch on that. That is so important. And it has been a bit controversial too lately.
Absolutely.
But we all, are from the school of thought that children need to be vaccinated, especially in schools. So tell us what you've seen and how that's moving forward in terms of our communities.
Right. The American Academy of Pediatrics preaches that we do these routine vaccines, and we have a vaccine schedule, and we have a catch-up schedule for those that may have missed. But vaccines start actually at birth. We get the first hepatitis B. And then we have a vaccine schedule that we follow at 2 months, 4 months, 6 months, and I just want to say we're not vaccinating to hurt these kids. We're vaccinating to help these kids. It's there because we're protecting them against preventable diseases that have been studied, and it has shown that this vaccine will protect you totally. And if there's a wax and wane on anything, obviously we're doing studies. Varicella was brought out, several years ago, but it realized that it started to wane and it needed a booster dose. So we added that second dose because there was a breakout in vaccine-related chickenpox. So what happened was they got the vaccine, but at a certain point, their titers came down. They realized they need to revaccinate.
So how many times do they vaccinate for the chickenpox?
2 times. 2 times. So they get one at 1 year.
Good, we're up to date.
and then there's a booster one at 4. But again, people may lose titers, and so even though they got the 2, sometimes they break through. But at the breakthrough, it's not as severe as if they never got that vaccine.
Absolutely. And there is a correlation between the chickenpox and the shingles.
The shingles, absolutely.
At a later age.
At a later age, and it's much more difficult to treat, and it's a lot.
I've had the chickenpox. So,
yes. So hopefully you won't get the shingles. You have natural immunity that you won't get shingles as well.
Oh, okay. So it's not if you've had the chickenpox you get shingles.
It's a dormant virus in your body.
Okay.
And so what happens is it may just flourish, and you get this flare. But it could be just from immunity changes as well.
Okay. Yeah. Okay. So I'm less immune.
Hopefully,
Okay.
I had a resident friend that actually had the vaccine, and because they have to check titers before they start residency to protect them, and he broke out with chickenpox as a resident. Yeah.
Oh, Lord.
So
he
lost his immunity, and I'm sure he got into contact with one of the patients that we had.
With the chickenpox.
With the chickenpox.
What about measles?
MMR, measles, mumps, rubella. We don't do just the measles shot by itself, but the vaccine has been controversial. Obviously, it's been in the news, and it's been there, and it's been showing that people are trying to correlate that vaccine with the cause of autism. But there was a study out that was published, and apparently the author that published it falsified information, and it came out several years ago that it was falsified. So there's really no medical correlation that shows that people that get that MMR vaccine, it's going to cause autism. That vaccine has been out for years, and it's very protective. And what's happening now is there's a rise in the number of patients that are not getting it, and the disease itself, and getting the measles. Now there's been an outbreak. It started in California, and it's been going across. So
basically,
it is a vaccine preventable disease, and now the fact that people are refusing to take it.
And refusing to give their kids
and now these kids are breaking out, and it's not just the kids; it's adults as well. Yeah.
So the risks of not taking it
is higher
far outweigh
of those.
The risks of autism and that correlation.
And we're trying to work with the families that come in, and some of these families are just so scared and hesitant and feel like, I don't want to vaccinate with this. They keep mentioning it. I said, well, this vaccine isn't right here at this time. It's at 12 months. And some of them will come in with a different schedule. I prefer to work with the schedule that we have, but again, when I say we need to build a trusting relationship with the family, I'm going to work with them because they're willing to work with me and getting this child vaccinated, but at an odd schedule. But I figured if I work with them, they trust me and I trust them enough that they're going to come back on this schedule, I will do that. And knowing that in the long run, that child is getting vaccinated.
Absolutely. And working with the parents' comfort zone is very, very
Absolutely,
important.
because again,
they want to make the right decision.
They want to make the right decision. I don't want to be forcing something on them because they're going to go elsewhere. and they're going to knock somewhere else. But if I felt that I trust them enough and they're trusting me enough, we're going to work together, then we can go forward.
You know, talking about vaccinations and major illnesses, when children come in, and even when adults come in with a fever or if they're very, very ill, they expect to walk out with some kind of prescription.
Right.
Now, obviously, there's a difference between a viral infection and a bacterial infection, and some people don't. I'm sick. I have a fever. I need antibiotics.
Fever, you're supposed to walk out with an antibiotic.
Right.
So
yeah,
that was one of the hard things that I had to deal with initially when I first came out into practice, because they were used to, I had a fever, I came in, they're complaining of a sore throat, I want that antibiotic, I want that pink stuff. And I look at them and and I started educating these people. I said, listen, I didn't want to come into them the wrong way. I didn't want to say, nope, this is not
this
it.
This is how it's done.
This is not. And I realized that education was key.
Sure.
And these people need to be taught that not everything is just an antibiotic. If we're giving you this antibiotic and then all of a sudden one day you need to really use it, you're building resistance against that drug. So I started, you start giving them little bits of information so that they understand. And I said, this is what's going on. You're going to expect 2 or 3 days of fever. This is a virus. Obviously, you need to rest them, hydrate them. Dosing them with Tylenol, Motrin, and giving them the right dosing is really important, because a lot of times they don't dose properly. So instead of with a spoon, I give them a measuring cup or a syringe, and really specifying exactly how many milliliters to be given, because inadequate dosing really doesn't treat. So they will say, oh no, the fever didn't come down because they weren't dosing properly. And explaining to them, this is the course of the pathophysiology of the disease. If the kid had mouth sores and they were complaining of sore throat, well, they think they're going to get an antibiotic, and it's really all viral. Okay. And I tell them the progression is they're going to get worse the next couple of days. You might break out in a little more sores outside the body, and within that time frame, you'll start realizing that they might drool, they might do anything. When they see that and they realize, okay, I was right, they're going to understand me better. So again, it takes time, it takes a little patience. A lot of times parents are difficult when they come in, but I got to remember, I was a parent too, and you were a parent.
Absolutely.
And when you have a child that keeps you up
for that child
all
to
night
feel better,
and they're not doing well,
sure,
and they're fussy and they've had no sleep, I got to be sympathetic and empathetic.
Absolutely.
I got to understand, okay, they're going through a difficult time, and I need to comfort them as well as take care of the patient. So sometimes I'm taking care of two, not one.
Sure, you're more than a doctor, especially as a pediatrician. You have to be a social worker and a psychologist
and a friend.
And a friend.
And a friend, seriously, and a friend. And a lot of them I do. I mean, a lot of this is social history, and they really appreciate that. They understand, they had something going on, and you remember that at that next visit. They really appreciate that.
Sure, absolutely. Yeah. But really quick, I know, even as adults, when you go in and you're sick, you want an antibiotic. But that conversation is really important to know the difference between, what a bacterial infection is that needs an antibiotic and what a viral infection is. And you had mentioned it earlier. People become resistant to antibiotics if they're taken when not needed, and I think we've seen that.
What
in the
we're doing now is a lot of these kids,
industry,
especially if they're coming in with a sore throat, and most of the times they're really viral. I'm swabbing their throats, whether I do a rapid strep test to get it done in the office, and a lot of times the sensitivity is not as great. So I like to do a throat culture and send it to the lab. It may take a couple more days, but I have a conclusive answer. And I tell the parents, I said, let's wait it out a couple of days. But if clinically they look like they are strep throat, I will then go ahead and start. But if it's not, I would say, let's wait it out and see what the culture shows. Let's not start antibiotics if they don't need it. Right? Start it and stop it if it's not the case. And they're understanding with knowing that I'm going to follow up with them, and I'm not leaving them hanging.
Oh, absolutely.
And sometimes they may have an ear and a throat infection. Well, you know what? You've got another thing. If they're complaining of an earache and they're miserable, they're fever, they're up, they're going to get an antibiotic as well.
Well, definitely ear infections definitely need antibiotics.
Yeah.
I lost my voice. Exciting football games over the weekend, I guess. But children in general, you see them from birth to 18 years
20,
old. Yeah. So when they get into school, again, there's other issues that they face. ADD and ADHD seems to be very prevalent.
Yep.
So much more now. I mean, the increase in numbers of cases that have been reported has.
That's why the development is important about this.
Yeah, yes. from the 50s, 60s, 70s. So what do you attest to that, and how are we dealing with this in our schools?
The prevalence is up. It's going up. Obviously, the statistics show that it's actually more in boys than in girls.
Right.
And we do tend to make that diagnosis in around 7 or 8 years of age. But there are some kids that skim through because parents want to call them hyperactive, and they just, they just need time. But a lot of times, and I tell the parents,
usually boys are diagnosed earlier than girls.
A lot more boys. Boys tend to be more hyperactive, ADHD, and girls are more attention deficit, the ADD without the hyperactivity. More than likely, the kids are they start coming in around 7 or 8, first grade, second grade. They're in school all day. And the classroom is full, and you've got a kid that's constantly off the wall, moving around and fidgety, and some of the times the parents are just saying, "No, my kids just work with it," so they don't want to deal with that stigma, and it really isn't a stigma, And I tell the parents, I said, "Listen, how is he at home, and how is he at school, and how is he outside in the social area? And if he has issues in every one of those, there's going to be an issue going on." And I tell the parents, I said, "Listen, if we're going to diagnose him, and you think working with him just with a therapist, sometimes it works, but majority of times it doesn't. It's really working with the teacher."
You advocate the medication part of it.
I do, in a sense, when it comes to kids that are really hyperactive. They're struggling in school. They're struggling with their peers. They become an outcast, and all of a sudden they have this issue with, "Oh, he did this all the time," or "She did this all the time." And I don't want that, because I don't want him labeled.
Right.
And that's what happens. So they become labeled from school year to school year.
So it's a disservice not to.
It is. And I tell them, I said to the mom, I say, "Listen, if this kid is struggling and sitting there with you for an hour and a half to do homework that shouldn't take him more than 20 minutes, and you guys are arguing with each other and at each other's nerves, you're not helping him. You're really hurting him." Or at school, the kid is constantly behind, missing his homework, forgetting this, not doing well in class. Then his persona starts to go down, his confidence goes down, and kids don't want to deal with that. So it really tumbles down. It just becomes a rolling ball that you need to stop, I say.
With your experience, what are the best medications that you've seen that
are
effective?
The medications, it's really a trial and error. There's not one specific medication that I like to use. It depends on the side effects, and there are side effects to the medication. Not everything is without side effect. And so I let them know out front. I said, we need to see, is his sleep affected? Does he have headaches? Does he have abdominal pain? Is his appetite? These are all things that we need to assess, and we bring them in routinely. So if anyone is diagnosed and starts meds, we bring them in monthly. And I tell the mom to tell the teacher to look out for issues. Is this dose? When we start dosing, we titrate up. We don't start up. We have to titrate to see what's an adequate dose with minimal side effects.
What about the heart? I mean, there's been conversations about, Ritalin or other
right.
ADHD meds affecting the heart.
We do an EKG beforehand. We check that. We do routine baseline labs to make sure everything's fine, and we do an EKG to make sure there's no cardiac issues. If there was, then we don't start meds until we get cardiac clearance.
But if there wasn't a cardiac issue, do the meds create one?
No, not
Over
at all.
time?
No, there was a black box warning on certain medications. I don't even use those medications, but the ones that I use are clear. But those that have, because it's a stimulant, we have to be careful.
Absolutely.
Yeah.
And how do you guide children from elementary school on up to high school? So is it the same kind of treatment, or does it change?
Well, usually it depends. Some kids end up staying on the same treatment, but as they grow, I have to titrate their dosing. And some kids, I've had to change different medications because as they've grown, it's not working. So we try to find the right meds. And now some kids stay on it all year round, every day, 7 days a week, holidays, vacations, summers, everything. It's just depending. And some kids literally take weekends off, vacations off, summers off.
And is that okay?
And that's okay,
I
because they only need it in school. No.
So it's okay to not be consistent with it.
Yeah, some kids can handle that. They don't need that. They can handle it on the off time. So we take it person by person basis.
Mostly for school.
Mostly for school. Some kids just need it in school. They need to focus. They don't have any issues with the hyperactivity. They don't have any issues with their peers. They just need that time to really sit and focus.
Do you encourage medication and
therapy?
Therapy as well?
Absolutely. For some kids that are struggling quite a bit and coping and understanding, especially if there's a lot of family stressors, therapy for the child as well as therapy for the family is important. And that trying to get that to the family is a big barrier. But we keep encouraging and we send them, and I tell them.
So family therapy is
family
important.
Therapy
it affects
because
everyone.
Absolutely. It's a family disease. It's a family diagnosis because this child lives in a family. He's not living on his own. And so it's how they interact also tells how he develops and grows.
Peer pressure as well.
Peer pressure,
and
so
social behavior.
That's why I said, if it becomes a social issue in school, kids don't want to deal with kids like that. They stay away, and then they outcast him. And then the kids outcast him, and what happens is, and it's just, I'm not saying the teachers do it intentionally, but when this child is constantly causing issues, then he becomes outcasted by the teacher. And it's just natural. It's not intentional.
Right. And there should be some tools in place too for teachers.
Absolutely. And so I tell them you have to be on the same page with the teacher. And that most teachers are willing to work with these kids. They help them, and I tell them you need an organized calendar. You need a planner. You need a backpack. You need notes, communication going back and forth between the teacher and the mom daily. Right. This is their homework. This is when it's due. This is how they did in school. This is what I want you to do at home, and it goes back and forth. Organization is a problem for these kids. So, yeah, they need to work with the teacher, with the parents.
Is it a continuous thing, though?
As they get older, their frontal lobe matures.
College, through marriage.
About 10 or 15% of these kids remain that into adulthood. And so what happens is most of these kids will take it during the school year. Some of them might take time off. Some might take it only like if they know they have a big project or an exam they need to sit, they take that meds. So, but because maturity comes into play, they find themselves sometimes not necessarily needing it as often as they were when they were younger.
And one more thing, there's a couple of other subjects I want to talk to you about, but even college-age kids seem
be careful
to take it only for exams, even if it's not prescribed for them.
Right.
How much of an issue is that?
That's a big issue. Yeah, it's being sold on the street per pill. And these kids, these college students, aren't really diagnosed with ADD or ADHD. And so they're using it to stay up all night as uppers and causing a lot of problems. So I really behoove anyone that buys these pills outside that are really not diagnosed with ADD, and I scrutinize every patient that comes in, and I make them come in every 3 months for follow-up, and they have to come in for themselves for their prescriptions. And if they haven't been seen in a while, say they haven't been seen in a year, all of a sudden they come in, they want a prescription. It's not going to happen.
Oh, okay.
It's a controlled substance.
We only have about 5 more minutes, so I can talk about this for a lot longer. But there's another issue in schools with the athletes and football.
And football season's upon us.
Absolutely, concussions and injuries. And for me, that's always been, my nephew played football and had a couple
my 3 boys play football.
And your boys play football as well. So
and I've had 2 with concussions.
And I love football. I love watching it. But for me, it's like people just attacking each other, and concussions are inevitable. So how are we dealing with that, and what's the long-term effect of kids getting concussions continuously while playing football in high school?
And you know, there's more out there now, and so now the coaches and the staff are all involved.
More cognizant?
Absolutely, and they're really pushing. Before it used to be, oh, just sit on the side and we'll be okay, and now they're doing concussion testing. They have baseline testing done on all these kids. They have sideline tests, so if the kid comes off outside and says, I just don't feel well, I have a headache, I'm dizzy, the trainers on the sideline are doing the baseline testing to see how they are. And they're actually wanting the players to be honest about it and telling them what's going on. And the coaches, if they see somebody on the field, they need to pull them off. And the referees are actually more into it too. So It's a big issue, and it's a long-term issue because repeated injuries and insults have long-term sequelae for memory issues, and
right,
memory and motor issues.
So if there's a child that has a concussion, so the only
if they don't pass that sideline test,
to keep them out of the game.
Keep them out of the game, but they have sideline baseline questions that if they don't pass that, they're not allowed to go back in the game, and then they're told to leave and follow up with their doctor and get clearance. Okay. So I've had kids that have gone to the emergency room and they were diagnosed, and they don't need a CT scan for diagnosis. Not every kid requires a CT. If there's any neurologic issues or symptoms or motor issues along with this, then they will do a CT. So you're just going to remember, a concussion is not based on a diagnosis by CT scan. It's clinical symptoms and what you're, headache, blurry vision, dizziness, motor issues, and if it's consistent, if there are headaches all the time. So a lot of times when these kids come in and I do diagnose them with a concussion, they need brain rest. They really do need brain rest. They can't have any contact. They're really not allowed to be watching TV or on their phone or on the radio. If it's that bad, we even tell them that they need brain rest from studying, because the more they sit and read and focus, it causes more of a headache.
Right. So the treatment basically is just rest. So there isn't no
exactly, and no physical play. You don't want that to come in and cause
stimulation.
No stimulation. So it depends on the level of the concussion. Depends on how much you are telling them to rest and when they can go back to play.
Talking about stimulation, we have a lot of issues especially within this area here, and we've got only 2 minutes to talk about it really quick. The hookah, the water pipe, it's everywhere.
It's a fad. It's a bad dilemma now. I'm not a hookah person.
Dr. Loubna Fakih, kids.
Kids, yes.
I've seen 6, 7-year-olds holding the hookah in front of their parents, sitting down,
and they think that's fine. It's cool. It's a cool thing. It's become the norm, which really isn't a good norm, because that hookah is so concentrated in nicotine. A lot more.
5 packs to 1 hookah is from what I understand.
Yep. And we're just doing more damage to our lungs and to the people around us. And it's just because they sit and it's a social fad, and it's cool, and now they have flavors and different type of
apple and watermelon and the whole
oranges, the whole thing. And I totally, when we ask as part of our physical, we ask about smoking. We also ask about this and e-cigarettes. Yeah.
And e-cigarettes as well. And e-cigarettes are not something to help you quit smoking.
Not at
all.
It's
as addictive.
It's a fad. It's another fad, and it's causing more injury to the younger kids who actually
who are still developing as well.
Who are taking that liquid nicotine and drinking it.
Absolutely. Also, I think hookah at the very beginning was pegged as something that was a little safer and a lot less addictive.
That's totally
and
not
now
true.
that
they're really understanding that it's
hopefully that message will come out. I mean, it's a lot
hopefully
more
the no smoking
dangerous
bans and limiting where you can smoke and all that stuff will help. Yeah.
I'm being told by Bob we got to wrap this up, but I could talk to you for another hour. Thank you for being with us.
Thank you so much. I hope you guys enjoyed some of the information and what's going on out there with our kids. And
absolutely, absolutely. Dr. Loubna Fakih, everyone, pediatrician, and a wonderful source of information. Thank you all for joining us on Community Connection. We'll see you next time.